Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, I'm Becca Catlin, one of your co-hosts of the AAOMPT podcast, as well as research committee member. Today I have with me three guests who are a powerhouse of knowledge and expertise in physical therapy. Together we will be discussing the article entitled Biomechanical Characteristics of Lumbar Manipulation Performed by Expert, Resident, and Student Physical Therapists. This was published this year in 2020 in Musculoskeletal Science and Practice. The three authors we have with us today are Joseph Derian, Joe Armour-Smith, and Kornelia Kulig. A little bit about them before we get started. Joseph is a physical therapist who is an instructor of clinical physical therapy at the USC Division of Biokinesiology and Physical Therapy. He sees patients in the orthopedic setting at the USC facility and teaches in the first and third year of the DPT program. Joseph is a graduate of USC and completed the orthopedic PT residency at USC. He also leads a research project studying how PT students learn manual skills, specifically manipulation, with the goal of improving manual therapy education. Joe Armour-Smith, who's also a physical therapist, is an assistant professor in the Department of Physical Therapy at Chapman University. Prior to beginning her academic and research career, Joe worked as a physical therapist in the UK and the US. During her years of clinical practice, Joe specialized in orthopedics and dance medicine and gained additional training in manual therapy at the University of Western Australia. Joe did her doctoral research under the supervision of Kornelia Kulig at the University of Southern California. Joe's current clinically motivated research program focuses on biomechanical and neurological factors that contribute to persistent low back pain in young adults. Joe was awarded the Margaret L. Moore Award for Outstanding New Academical Faculty Member by the APTA in 2017 and the Early Career Investigator Award in Biomechanics Research by the Section on Research Biomechanics Special Interest Group in 2020. And Kornelia Kulig is a professor and co-director of the Jacqueline Perry Musculoskeletal Biomechanics Research Laboratory at the University of Southern California. Her research is clinically motivated, theoretically informed, and experimentally tested. She studies human movement and postural control in conditions of seemingly musculoskeletal origin, characterized by frequent reoccurrence of symptoms. In that model, she studies peripheral and central adaptations to pathology with the aim to enhance the exploration of the impact of these conditions on locomotion and other functional activities. Her work is extensively published and cited. She has more than 100 peer-reviewed manuscripts. Educationally, Dr. Kulig was a prominent force behind the development of physical therapy residencies. She mentored several accomplished movement scientists who developed their own strong research programs. She is one of the founding members of the American Academy of Orthopedic Manual Physical Therapists. Her contributions to the physical therapy profession were acknowledged by multiple prestigious awards such as the Hyslop Award for Outstanding Contribution to Professional Literature in 2015, the 18th Melee Lectureship, and the 16th Nolan Lectureship of the Physical Therapy Association. She hopes that the example of her journey through the principles of scholarship encourages others to follow a journey of their own with passion, joy, citizenship, and commitment. It is certainly our pleasure to have one of our founding members with us today. This group would also like you to know that this research was supported by the Cardon Rehab Research Grant from the California Orthopedic Manual Physical Therapy Special Interest Group. And lastly, just for clarification, when we start into our conversation, the first voice you'll hear is mine, followed by Kornelia Kulig, and then the second new voice you'll hear is Joe Armour-Smith, and then the male voice you'll hear is Joseph Derian. I hope you enjoyed this conversation as much as we did. We have Dr. Kornelia Kulig, Dr. Joe Armour-Smith, and Dr. Joseph Derian. Welcome, all of you.
Thank you.
We'll jump right into your study and have one of you give us the premise of the study and the basic purpose.
So let me start from the motivation of the study. So the motivation is anchored in the educational environment in which we are right now. We work with master clinicians like Mike O'Donnell, who's actually an author of the prior study, Delphi study, Rob Blundell, Dan Karagias, and many others. We also have a thriving group of laboratory researchers and gifted graduate students where we can look at movement, quantify movement. And we have also been training residents for more than 20 years, if I look back at that now. And the discussion among these three groups, master clinicians, laboratory researchers, and residents, created this diverse background, created the idea for the study. As a group, we genuinely believe that quantifying movement leads us to a better understanding of the movement and then carrying that into education. So that was our motivation for the study. And out of this discussion, actually, came the question, how do we perform a common clinical procedure such as lumbar manipulation?
Fantastic for that detailed background. When you got into the design of the study and some of the questions you were asking, you did mention the Delphi study from Michael O'Donnell, and you and Dr. Joe Armour-Smith were both involved in that. What were some of the survey results on what clinicians thought resulted in importance in manipulation?
Yeah, I can start with that one. Yes, as you mentioned, the first part of this study was a Delphi study, as it's called, led by Mike O'Donnell, where we were aiming to better understand what clinicians and educators thought were the important characteristics of side-lying lumbar manipulation. And here we're talking about characteristics in terms of what the therapist is doing or how the therapist is moving during the manipulation, and we also were interested in the patient positioning. So we conducted this quite large survey where we aim to get this consensus from clinicians and educators about what they perceive to be the important characteristics of the manipulation. And from that process, which is sort of this iterative process over time, the consensus emerged identified a few different characteristics, and they included speed very much. Most of the clinicians and educators identified that being able to drop downwards rapidly with the body and legs was very important, that keeping close to the patient was important. So that sort of then helped us when we were beginning the biomechanical part of the study to help sort of identify what were the things that we needed to measure.
Thank you. Since I have three of you that were involved in this study, did you each take different components or parts that you were primarily overseeing through the development of the study?
Yeah, if I could speak to that a little bit. So I started my participation working on this research project actually while I was still a physical therapy student. I think primarily when I was in my third year, started coming on and helping design the protocol, the methods, and I was mainly involved with data collection process. So it's recruiting students. The study progressed to when I was a resident too. I was recruiting students both in the third year and the first year, working with them in the lab, getting the data collected. And then we all worked together on sort of looking at the data and trying to decide, well, what is actually happening here? What are the important things that are happening? Does it relate at all to the study we talked about just a second ago, the O'Donnell study? Does what's happening in the manipulation actually represent what people think is important in the manipulation?
Thank you. And then, Joe, did you kind of take over the biomechanics? It seems like that's a big part of your background, or am I assigning you tasks that you didn't necessarily give up?
Well, I think this was a group project, and Cornelia has always been the sort of the driving force of really being able to link the educational aspects of this, the clinical aspects of this, and then the biomechanical aspects of this. And I trained with her at USC. Yeah, I ultimately primary role was in the biomechanics of this, initially with the data collections, which Joe then took over, and then with some of the analyses.
I appreciated what Dr. Kulig said initially on just the diversity of the backgrounds and how that combined to create the various facets of the study, trying to tap into your different skill levels and expertise. in different areas.
Yeah, and actually, if I could just jump on that while we're talking about that, I wanted to give a shout out to one of our research assistants, Wesley Wong, who did a lot of kinematic analysis looking at the 3D models and spent a lot of time on that. So just give him a little shout out and tell him thanks for all his hard work.
Yeah, and also Wilson Lamb, who did a lot of work with the ground reaction force data as well. So yeah, this has certainly been a team project.
Let's get into a little bit about how you designed the study. So we understand the purpose, but can you give us the nuts and bolts of how you implemented it?
Sure, and I'll maybe if I take a first pass at this, and then my colleagues can join in and fill in anything that I miss. So we had groups of participants come into the lab, and briefly we had four groups of participants. We had experts manipulators who had been performing manipulations clinically and also teaching manipulation, and they had on average 40 years of experience, so they're highly experienced experts. Physical therapy residents, a group of third year DPT students, and a group of first year PT students, DPT students. And for each group, we brought our participants into the lab and they performed a total of 4 manipulations, side-lying lumbar manipulations on healthy, what we'll call patient models. And as they performed the manipulations, we were measuring motion of the pelvis using 3-dimensional motion capture. So we had them instrumented with motion capture markers on the pelvis and the spine. We were also measuring ground reaction forces with force plates. So the participants stood with a foot on a force plate on each of 2 force plates, so we could measure what the back foot and the front foot were doing during the manipulation. And then for each repetition of the manipulation, the participant would sort of set up their patient model, get them positioned, and then when they were ready, we would start collecting the data. They'd make their final small adjustments and then perform the manipulation. And then from that, we were then measuring our variables during the thrust phase of that. And specifically, and again, sort of based on what we had learned from the survey study, from the Delphi study, specifically what we focused on were, I guess, 3 main biomechanical characteristics of the manipulation, which were the motion of the pelvis, so the angular motion, rotation in all 3 planes, and the linear motion of the pelvis. The motion of the center of mass, so where, as you know, center of mass will sort of give us a measure of what the whole body is doing, and then also the ground reaction forces under the feet to get a better understanding of how the participants were generating the forces necessary for the manipulation. And I know it's hard to visualize this, but in all cases, the patient models were laying on their right side, facing the therapist, the participants. So if you imagine that you are the therapist and you're now facing the patient on the table, your left side is up towards the patient head, your right side is down towards the patient's feet. So as we sort of start to describe the results, that's the orientation that might be helpful for understanding the positioning and the motion.
And then you had standardized your models, correct? So they're about the same size and the same gender?
Yes, so they were all male, all healthy, as much as possible, similar sizes.
No history of back pain?
Yes, so we excluded people who had any of the contraindications for manipulation. They had no history of back pain, and we did assess them in order to determine a hypomobile segment in the lumbar spine.
Each participant clinician got to do 2 manipulations on 2 different bodies, is that correct?
Yes, that's right. So exactly. So each clinician participant performed a total of 4 manipulations, 2 of them on one patient model and 2 on another. And that was helpful because then it meant that we could provide a time period between each manipulation so that we weren't having the same person manipulated over and over again within a short period of time.
Good idea. The variables that you calculated, can you state those again?
Sure. So we did 3 things primarily. So in terms of the pelvis, so remembering that we were collecting or we were measuring motion of the pelvis using 3-dimensional motion capture. So we looked at angular velocity of the pelvis in 3 planes, so sagittal plane, frontal plane, and transverse plane. During the manipulation, we looked at the center of mass, and we looked at how much the center of mass was moving vertically, so displacement of the center of mass vertically, and also acceleration. So during that downward part of the thrust, as the person drops downwards, we measured the peak acceleration. And then we looked at a number of characteristics of the ground reaction forces. So remembering that the participants had a foot on each of two force plates, so we could measure the feet individually, looking at how their weight was distributed between the 2 feet at the beginning of the manipulation, and then as they performed the manipulation, how they essentially modulated those ground reaction forces, how quickly they sort of unloaded the feet as they dropped downwards.
Great. So you had initially 3 markers, the L5S1 marker and then an ASIS marker?
Yeah, we had, so for three-dimensional motion capture, we first sort of defined the limits of the segment. So that was done with markers on the greater trochanters as well, which sort of defines the lower limit of the pelvis. And then, as you said, a marker on L5S1 interspace. And then on the iliac crest. So we were sort of going for a balance of being able to capture this adequately, but also not making the setup too cumbersome so that the practitioner, therapists, participants were too sort of impeded from performing a normal manipulation.
Okay. It must have ended up with quite a pile full of data that you ended up having to sift through. How many practitioners were there in each group?
There were 15 first-year students, 13 third-year students, 11 residents, and 4 experts.
And as was already mentioned, the average years of experience for the experts was over 40 years, which is quite impressive.
Yeah, they were a powerhouse bunch for sure.
Was there very much difference in experience between the third year students and the residents? Or was it that most of the residents go into their residency program pretty quickly after their entry level program?
That's a good question. The way that the data collection took place is the third year students were tested at the end of their final lab skills course in the DPT program. And at USC, the third year students are split into 2 cohorts that either take that course in the fall or they take it in the spring. And then the other semester is a full-time 16-week semester-long clinical rotation. So they were either doing it late in the fall or late in the spring, depending on their split of the cohort. Oftentimes, residents did go, or third year students would go straight into a residency. There were a few residents, I don't remember specifically which residents did or didn't, like take a year of clinical practice and then come back to do the residency. But the residents were also tested near the end of the residency once they had gone through all of their seminar series of manual skills courses, which include manipulation. They had sort of like a journal night about manipulation where they talk about research and practice it as well. They had at least a good little bit of extra didactic experience or clinical practice on top of the third years, but it wasn't. It's nothing like the difference between the residents and the experts. I think that's a good point to bring up.
So let's talk about the results. Who wants to run through a little bit of the synopsis of your results?
Let's talk about the pelvis first of all. And again, if we can sort of imagine in our minds that we are the therapist, we are facing the patient. The patient is laying on their right side, facing towards us. Our left side is up towards their head. Our right side is down towards their feet. That's our setup. So when we looked at the pelvis data, what we found was that the experts had faster motion in the pelvis, and I'm talking now about angular motion, so rotation of the pelvis, in both the frontal plane and in the transverse plane. And they were actually rotating the pelvis not only faster, but in a different direction from the less experienced groups. The experts, as they performed the thrust, were dropping the right side of the pelvis down, or dropping the right hip, if you will, down towards the ground, whereas the other groups tended to do the reverse of that. And the experts also rotated the pelvis very rapidly towards the head of the patient. So that's left rotation of the pelvis. And again, not only did they do that faster than the other groups, but it was the different direction. So you can sort of visualize the pelvis and the experts dropping downwards and rotating rapidly towards the left. They did the downwards motion of the pelvis and the center of mass, so the speed at which they were sort of dropping the whole body down and the acceleration of that was significantly faster. And then in terms of the ground reaction forces, we found that the experts tended to have more weight under their left foot, so the foot closest to the head of the patient. They were loading more onto that foot at the beginning of the manipulation as they began the thrust. And then the rate at which they unloaded the foot, so what we see with the ground reaction forces is that they decrease very rapidly as the person drops downwards. And the experts, what we call the rate of unloading, so how quickly that ground reaction force changed under the back foot was significantly different compared to the other group.
Just a clarifying question. You did a good job of explaining that. I have a pretty good visual. So the experts had more weight on their left foot at the beginning,
Yes.
and then they unloaded the left, and then did they load the right foot towards the end of the minute?
The answer is yes, but that sort of actually was not one of the things that we found to be most interesting in this. So certainly, if you imagine, or if I can sort of talk through what the ground reaction forces look like for either foot, right before the person starts the manipulation, there's an increase in the ground reaction forces. So people generate a little bit more ground reaction force right before they start the thrust. Then they drop downward, the ground reaction forces decrease very rapidly, and in some cases zero. They kind of offload the foot completely. And then once the person gets all the way to the bottom of the manipulation, right after the center of mass has hit its lowest point, then we see an increase in the ground reaction forces. But what we found to be most meaningful was sort of the beginning of that, and then the rate at which that decrease in ground reaction forces occurred. So how quickly all of that was happening on the way down.
Okay.
If I could add to that a little bit, I think that was sort of one of the more interesting or confusing results that we first got when we looked at the data, because traditionally, at least in the USC program, probably in other manipulation education programs too, is students are often taught to drop their right heel or back heel down toward the ground to kind of control their thrust or to help with their body weight shift. And so what we expected to see at first in the data was on that right force plate under their back foot or right foot was a big spike in the ground reaction forces as they finished the manipulation. And that actually didn't occur at all in the experts, and really there was no discernible pattern of it in the students very much either. And sort of what we came to the conclusion was that it's not really that people are shifting their weight from one foot to the other or landing on that back foot. It's the more important piece is that they're dropping rapidly in the first place, and then once you've done that drop and lowered your center of mass and decreased the ground reaction forces, everything that happens after that, once you've reached sort of your peak lowest point, it's just like a recovery. You're just getting your weight back on your feet, taking it off the patient. And so it was sort of interesting because that's one of the classic things I think people teach in manipulation is drop your back heel when you're doing the thrust, and that's something we didn't see.
Well, very good. Thank you for that explanation. That was interesting. Very helpful. Can you describe how you assess the beginning of the manip versus the end of the manip based on the data you had? Because you explained it in there pretty well.
So the start of the manipulation was defined as the highest point of the center of mass. So people generally, think of the manipulation as dropping your weight, pelvis, or center of mass. We started with, I believe, what was the highest point of the center of mass was our starting point, and the lowest point of the center of mass was where we called the end of the manipulation or the end of the thrust phase, which Joe mentioned we were mostly interested in. And I believe I'm getting confused because we're working on another manipulation study right now with a very similar method. So correct me if I'm wrong, Kornelia or Joe. For the ground reaction force data, we used a different start and end, which was the highest ground reaction force to the lowest ground reaction force, which sort of lines up to the highest and lowest center of mass, but it's not always directly related.
Okay. Were there many differences that you found between the residents' third years and first years?
That's a really good question. And the one thing that we did find to be different, specifically between the residents and first years, was the peak downward linear velocity of the pelvis. For many of the variables, we found these differences between experts and then the less experienced residents and students. But the peak downward velocity of the pelvis showed this more sort of stepwise, if you will, characteristic where it increased from first years to residents and then continued to increase from residents to experts.
Yeah, I'm looking at the table 2 in the research paper, and it is pretty significant that the experts were better on almost everything compared to the first years. By the time they compared the experts to the residents, and this is why I was interested in which skill acquisition seemed to come first and maybe what come later. There's several things experts compared to residents, like pelvis peak vertical, center of mass vertical, center of mass peak vertical, and then some of the foot things that the experts aren't statistically significant compared to the residents. You might be able to elaborate on that. Did you see any patterns of things that seem to be learned first versus things that come later in the learning?
That's a really good question. I don't know if Cornelia or Joe have a good answer for that. I would say that we sort of did see that this aspect of the speed of the pelvis dropping downwards was something that seemed to discriminate well between groups. And I'm not completely answering your question there, but that it did seem to sort of improve sequentially over time through the as experience increased.
I really think that's an interesting question because that's not necessarily how we might have approached this or thought of it as like, okay, what differences or like what stage or what order do people learn these different pieces in? That's sort of an interesting way to think about it, and that's not something I at least my personally haven't put a lot of thought into. I would say that Joe was saying that the pelvic velocity would probably, you could assume that would be getting stepwise sort of better as people got more experience, and because pelvic velocity is getting greater, you'd assume the ground reaction forces are probably dropping quicker as well, as their pelvis is sort of movement is related to their ground reaction forces through the feet. The only thing that didn't seem to change between all of the groups and then completely changed with the experts was the pelvic velocity and the direction of their pelvic motion. All the residents first years and third years had that similar or variable kind of direction of the rotation of the pelvis, and all of the experts ended up rotating the opposite direction. And whether or not that was something that happens from training, being trained at USC doing manipulation versus some of these experts were international learning manipulation in different places, was sort of a question that's hard to answer.
I also am really impressed by this question. So clearly, the task is obvious to everybody that it has to be done fast, and it's a ballistic movement. It's shorter than 0.3 seconds, and both the expert and the student knows that it's supposed to be done fast. Considering that the experts are older, way older than the students, clearly the students have the capacity to move fast, maybe even better capacity to move fast than the experts. But it's a combination of the movement pattern that they have to impart and interact with the subject. That aspect makes it difficult. The combination of learning the skill and imparting the movement, controlling one's own body and the body of the model, makes that preparation for the task and then carrying out the task difficult. I would love to have continued that conversation in the future.
Thank you all for answering that one on the fly. Very good assessment of your information to hypothesize about what the differences are. So I want to get into delving into how we can apply this. After you've gone through and assessed your results, is there anything that you've been able to take back into the students and change how you're teaching? Is there any direct application that you've been able to provide your students, and or what would be the next phase of research, or what would you do next to then get that information that's more clinically applicable?
Sure, I can speak to that a little bit. And something to keep in mind in this study is that we refer to experts having better pelvic velocity or better rate of loading. And I think that's fair to assume. We really don't know, what makes a good manipulation. All we can kind of really make observations on is what is different about the experts and the residents. So as sort of like trying to be as pure as possible to just what is happening. So we assume that the experts are better at manipulating. That sort of is a given, and there's sort of like the gold standard that we would want to hold our students to. So if we can make the students' manipulations biomechanically with these variables we've identified that as being different look more like the experts, then we can assume that their manipulations are getting better, at least from like a overall body movement perspective. So the next phase of this study that we're working on currently is we have students come into the lab with the very same setup, same motion capture markers. They're on force plates. Patient setup is the same. Models are normal asymptomatic models. And the first two manipulations they perform are just as they learned. They get a prompt that says, perform the manipulation as you normally do. The second two manipulations are perform the manipulation as quickly as possible, as quickly as you can. Or I'm sorry, the actual wording was, I think, drop your weight as quickly as possible. We took some time to look at motor learning literature and think about the cues that we were using, trying to not make it too complicated or to sort of piecemeal to make them think about all the different body movements. Because like Dr. Kulig was saying, it's such a fast movement that you can't really think about it. You just have to sort of plan and execute. There's two manipulations as they currently perform, two manipulations with that extra instruction to drop their weight as quickly as possible. And now we're analyzing to see what are the differences between that initial condition and this modified condition. And do the manipulations under the modified condition trend toward looking more like the expert manipulations? Did it improve their pelvic center of mass velocity? Did it improve their pelvic angular velocity? Did it change the direction of their pelvis? And those are things we're still sort of trying to work through in the data analysis phase.
Can you repeat what the second cue was to the
Yeah, the
students?
second cue was focus on dropping your weight as quickly as possible. And that's something that we didn't, is not really pulled from a source, but sort of just devised out of thinking about some of this, the motor learning and instruction, literature based on, internal versus external focus and simple instructions, implicit instruction versus explicit instruction, those kinds of things.
We focus a lot on giving external cues. We teach that for teaching patients exercises as well, lots of literature on that. And I was pleased to see in Dr. Kulig's bio, was part of a study on that in 2018. Do you have anything to add on how we teach using internal versus external cueing, Cornelia?
Yeah, certainly brings especially with fast movement, may be relevant focusing on cues external to it, external to the body. And maybe in manipulation that application is very useful. And certainly a number of experimental studies have supported that idea. Not always. And we don't want to say one must only provide external cues. But in this case, especially the way you anchored the questions, what do they learn first, speed or movement pattern? I think that is nice to tease out. That maybe with the external focus, that makes it a better instruction, makes it for a better instruction.
That study that you just mentioned, Joe, I'm really anxious to see the results of that. That'll be interesting. So many lines of study that you can then go from there once you learn how well they're able to adapt a single cue.
That's the goal. Yeah, things are promising so far, but we're still sort of working through it. And this is with third year students, so hopefully they were a little more familiar, and able to actually change their performance or adapt to an instruction. So we'll keep you updated.
Was there anything else that you were able to, or you've considered, I guess, pulling from this study and then bringing it back to the students that you can apply to them now, or other lines of study that you were thinking of?
That's a good question. I think, well, actually, I will say that I have lessened my sort of emphasis on the drop your heel down. And what we learned a lot from the experts is that we stopped referring to front foot and back foot. Like, for example, in the manipulation setup that Joe was talking about with right side lying, so your left side is toward the patient's head, your right side is toward the patient's feet. The students and younger manipulators, and even people who just learn it differently, might get into a really big stride stance, right? Have one foot way in front, one foot way behind, and drop down onto that back foot as they shift down into their thrust. And when we were looking at the videos of the experts, we were looking at these kind of videos in slow motion and watching their movement in the 3D models as well. And they really didn't have their feet in such a position. They were more squared off, and both feet were sort of a similar distance from the table, and they pretty much went straight up and straight down. And so I've changed my sort of idea of teaching this to being less about, okay, front foot, back foot, drop down on your heel, to more just like, to use a phrase like body up with the patient, get close, and then when you thrust down, just drop your whole body down, whether you go on both toes and drop down or just bend your knees. Different based on people's different heights and morphology. But one of the other things that it's hard to address in this particular study or with this data is that sometimes students' upper quarter isn't necessarily engaged either. I think a lot of people have seen this where a student does a manipulation and from the lower half of their body they're dropping very well, but where their elbows are placed or their forearms are placed on the patient, both of their scapula just elevate and they kind of shrug as they lower the rest of their body down. So really, they're not imparting a lot of force. Maybe that's hard to describe.
No, I know exactly what you're talking about. They kind of lose their tension from the top to the bottom, and it
Exactly.
just
Exactly. So there's a lot more to address, I think, in other portions of the body, and this is the difficulty, like Dr. Kulig was saying, with this kind of skill is it's 0.3 seconds or quicker is the thrust, and getting your entire body to get like an isometric contraction in all of your upper body and have your lower body move the right way, and your trunk is contracting for force as well. It's a lot to do at once, and it takes time for people to understand how to put all those pieces together and not try to cognitively think about doing all of it because that slows you down too much.
absolutely. This has been great. You guys have all contributed a ton to the profession with the amount of research that has been put out
My
amongst
colleagues more
you,
than I.
and just the being on the ground level with the students is a huge contribution to the profession. The last question I'd like to just throw out there, just see what you all have to say, given your vast experience and knowledge, is if you were going to give advice on teaching manipulation, whether it's based on your experience, it's okay if you give an experiential answer versus research based, what would you tell aspiring manipulation instructors on some good advice for teaching manip and or for students trying to learn the manip? Is there any pearls of wisdom that you can dispense?
I'll give it a try. Although we speak about manipulation as a skill, and certainly some of us are a lot more skilled than others, and it seems to be, we always think of it as almost an athletic skill. The advice is to really pay attention to the anatomy and the three-dimensional structure of the human body, understanding it through the study of anatomy and application of anatomy. And think while you practice, and then practice, practice, practice.
I'll definitely echo that. I think practice of the skill is important, and even when you come away from that, mental imagery practice is can be useful. Just trying to think about what it would feel like to do that movement. And people learn things different ways. Sometimes people can watch a movement and replicate it very well. Sometimes people need to try it out themselves. Sometimes people need to have the movement or the manipulation, for example, done on them, and then they can feel, oh, that's what it's supposed to feel like. Now let me create that myself. And so I think a lot of all those different conditions, if people figure out what works well for them, that can help. Whether it helps to have someone do it on you versus you do it on someone else in practice, or you just watch it a million times and think about it. In terms, I'll echo the things I said before as well. Is just simple instructions, I think, tend to help more. Implicit instructions, as much as you can for these kinds of skills, can be important. And focusing on trying to complete the skill with your whole body is the tough part. And sometimes too many little instructions like, oh, put your foot here, move your elbow there, you're going to do this and this and this, tend to break that apart a little bit. So I would say that less is more sometimes with these kinds of things.
That reminds me of some of the studies in the sports literature where they compared how they had people shoot a basketball or swing the golf club, focus on the rim versus tuck your elbow in, flick your wrist. Gave them one simple external cue to focus on and achieved better outcomes in their basketball shot or golf
Absolutely.
swing.
Joe, do you have anything else you want to add to that?
No, I don't think so. I mean, I absolutely agree. I think what we've all just sort of said is that I think as physical therapists, we now have a pretty good understanding of how we can best help people when they're learning a motor skill in terms of, what are some of the types of practice and the feedback that we give and the instruction that we give, how all of that can be really influential in improving people's ability to acquire a motor skill, whatever it is. All of the things that we've just said, the practice, the instruction that we give, practicing on lots of different bodies, watching peers performing the skill. All of these sort of principles apply as much to teaching PT students how to do this as they do to teaching patients to do something in the clinic.
Thank you all so much. I really appreciate our conversation today. I learned a lot, and I appreciate all that you're doing for our profession and helping increase the body of research to help us continue to be better clinicians and better teachers.
Thank you.
Thank you.
Thank you. It's been a pleasure.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.